All right. Well, hello, everybody. My name is Shana Costello, and I am the Senior Program Manager for the American Heart Association's Cardiogenic Shock Registry. And I am just thrilled to welcome you all to the kickoff of our Cardiogenic Shock virtual Grand Round. So thank you so much for spending part of your day with us. We have a really great call planned for you. And Rachel, if you could just go to the next slide. Just a couple of quick housekeeping items before we dive in. Please note that this meeting is being recorded and the recording will be archived on the registry's website. And we just ask that everyone please stay on mute unless you have a question. And then really we're asking that you hold your questions until the designated Q&A time. We will have one for each of the presenters as well as one at the end. And then, of course, you can feel free to submit questions into the chat, and we will be sure to address those during the Q&A as well. So I'm going to go ahead and hand it off to Dr. Morrow, who is going to get us started. Thank you.
Thanks very much, Shana. I'm Dave Morrow. I'm the director of the Cardiac Intensive Care Unit at Brigham Women's Hospital. I'm a critical care cardiologist, and I'm also the co-chair of the American Heart Association Cardiogenic Shock Registry, and it really is my pleasure to moderate this session today, this virtual Grand Rounds, along with Mitch Krukoff from Duke University, who is my co-chair for the Cardiogenic Shock Registry. And this is, as Shana was introducing, this is the very first in a series of virtual Grand Rounds that will be hosted quarterly by the American Heart Association for all of those who are engaged in the management of patients with cardiogenic shock and improving the quality of care that we provide to this extremely high-risk population. And today's program is deliberately quite broad. You can see the agenda on the slide. We will then, in future sessions, dive more deeply into areas of shock care that interest all of you. And so initially, we'll have an outstanding lecture from my colleague, Dr. Erin Bahula, who is an associate professor of medicine at Harvard Medical School, an investigator at the TIMI study group, and a world-renowned expert in cardiogenic shock. And then we'll hear from Amanda Garfinkel, one of our outstanding advanced fellows at Brigham Women's Hospital. And then we'll have a little bit of time at the end after a case-based presentation to introduce you to the AHA Cardiogenic Shock Registry. So with that, I will turn things over to Dr. Bahula.
Great. Well, thanks so much, Dr. Morrow, and Dr. Krukoff for having me today. I'm super excited to be here. So my task, as you see here, is to talk about the evolving epidemiology of cardiogenic shock. This is something that is very near and dear to my heart. I'm a cardiologist, as you heard, and a critical care physician, and I see these patients a lot. And it's a very exciting time in this field, in that we really are starting to get a much better understanding of this patient population. And as you'll hear towards the end, obviously much of this understanding has come from all of the insights that we've gained from, collaborative network and registries, much like the one that you're participating in, the AHA Cardiogenic Shock Registry. And apologies, I don't know if you can see my camera, but I am having challenges with it. I'll try to stay on camera, but it intermittently goes off. And so maybe we can move on to the next slide, and my disclosures are shown here, none of which are relevant to this talk. We can move on to the next slide. And so today, what I was hoping to do is to sort of set a basic groundwork. What are the definitions that we are using nowadays for cardiogenic shock, but then also to really dive into the nuances that we're starting to better understand about our patient population that we're caring for, and how that relates to the epidemiology and the outcomes of our patients. And so with that, we'll move on to the next slide. And I think before we get into definitions and, epidemiology, in terms of those sub-classifications, I think it's worth defining the scope of the problem. And This is just another plug for the sort of the importance of collaborative efforts. You'll hear me throughout this talk about a number of different groups who've put together collaboratives to better understand this disease state. One being the Cardiogenic Shock Working Group. I'll show you a lot of their data today, and then another being one that Dr. Morrow led and started back in 2017, which is the Critical Care Cardiology Trials Network. And I'll show you data from our registry, sort of the initial effort of this group, which is a collaborative now of about 40 centers across North America and a few international groups. But this was the very first effort that we did, which is we put together a registry to try to understand who's coming into contemporary cardiac ICU. And the reason I show you this is the admissions indication. So why are patients coming to the cardiac ICU? What is the reason for coming? And what you see there is about 20% of the population, or 1 in 5 patients, are entering our doors in the CICU with a diagnosis of shock. And if we move on to the next slide, so it's a highly prevalent condition that we see very commonly, and obviously, the morbidity associated with that is huge. Substantial resource utilization to support these patients. Their ICU length of stay, their hospital length of stay is significant. The amount of high-level advanced therapies that we're providing, the majority are requiring mechanical ventilation, some sort of invasive monitoring, the use of vasoactive medications, or mechanical circulatory support. And we'll touch on this much more in future slides, but obviously the mortality of this patient population is huge. In contemporary registries, we're talking on the order of 30 to 50%. So the scope and the reason for focusing on these patients is clear based on what I'm showing you here. And so if we go on to the next slide, we'll take a step back then and just say, okay, how do we define these patients, both, at a sort of broad level, and then again, some of these more nuanced subclassifications that we're starting to understand. And I think it's always fun to dive into some of the historical references that we have. And this is a paper back from 1976 from the famous Dr. Swan of the Swan-Ganz fame, where he and colleagues looked at invasive hemodynamic parameters and tried to define thresholds for those things that we think about as being sort of core or critical to the definition of cardiogenic shock, like hypoperfusion and pulmonary congestion. And they were able to define thresholds for those, for the cardiac index and the wedge, and then link that to mortality. So sort of a neat historical reference. And we still use these thresholds in many of our studies to date. If we go on to the next slide, this data was then carried into definitions that were used, over the last several decades. Many different definitions that were out there, whether it was talking about sort of clinical definition or trial definitions, huge amounts of variability in terms of the specific thresholds and the individual criteria. But generally speaking, they were characterized by a couple of things, by evidence of an organ hypoperfusion, end organ hypoperfusion. We'll come back to that in a minute. Some documentation of ineffective cardiac output, either clinically or with hemodynamics, and generally speaking, some evidence of congestion. And depending on the specific trial or criteria, whether or not many of them had criteria for hypotension. If we move on to the next slide, importantly, now a number of our cardiologists, including Dr. Morrow and Dr. Krukoff, got together and said it's time for us to standardize our definitions. And so this group, the Shock Academic Research Consortium, or SHARC, created just recently, just this last year, a set of definitions that did just that standardized how we think about cardiogenic shock. And at its core, the definition is a cardiac disorder that results in hypoperfusion. And they set specific criteria for what hypoperfusion was, meaning any one of the following, at least one of the following: an elevated lactate with that threshold, evidence of acute kidney injury or acute liver injury, pool or mottled extremities, and then altered mental status. They also provided specific definitions that could be used for clinical trials, where they set a threshold for hypotension, which is oftentimes inclusion for clinical trials of shock patients. And then importantly, this paper also acknowledged that not all patients with cardiogenic shock, if you advance further, have hypotension. Oh, I think it got lost on there, but they also did acknowledge in this paper that there is an important subclassification of cardiogenic shock patients who have normal blood pressure. So an excellent paper if you haven't had a chance to look at it. Discussed in that paper, and I'll also talk much more about this, is that there are many, again, nuances to how we've sort of begun to understand our patients with cardiogenic shock that are very important for a number of different reasons. You know, we think about now about the etiology. Are these patients coming to us in the context of an acute MI or what we call AMI-CS? Are they coming with acute decompensated heart failure or heart failure CS? Do they have some secondary cause like valvular disease that's driving their cardiogenic shock? What's the pathophysiologic state of these patients? Are they classic high SVR cardiogenic shock patients? Do they have some superimposed vasodilatory component or mixed shock? What's the chronicity of the pathology that we're seeing here? Is this their first presentation, or are they de novo, in other words? Or is this an acute oncrotic sort of stuttering process that we're now seeing manifest as cardiogenic shock? What's the ventricular involvement? Is it left-sided, right-sided, biventricular? And how severe is their presentation? And all of these things are very important if we move on to the next slide. I think ultimately they'll be important for how we manage patients, defining these different things. But what we know for sure is that these different factors contribute to outcomes and tell us a lot about risk stratification and what the patient is, you know, what the patient's course is likely to look at. So things like I already mentioned, etiology, chronicity, severity of illness, specific hemodynamic criteria are important in outcomes. And so we'll dive into those in more detail in the upcoming slide. So if we can move on to the next one. Talking specifically about outcomes and mortality, again, taking a little bit of a trip down memory line and looking at the historical context. This is a real seminal paper from Killip and Kimball when they defined the Killip classification back in 1960. And looking at the various levels of Killip classification and outcomes in patients who presented with acute MI and cardiogenic shock. And the reason I show you this is just to show you that back at that period, the hospital mortality for patients who had shock was 80%. So, you know, absolutely horrific outcomes back then. If we move on to the next slide, fortunately, things have gotten better. And so we, as I said, back in the 60s, 70s, 80s, if we can go back one, mortality of 80%. Then came the shock trial, where we learned that, you know, early mechanical revascularization improves outcomes. We started to see that mortality decline down into the order of 50%. And then more recently in contemporary registries, it looks like the mortality is around 40%. And so this on the right is just a representation of within one data set out of Worcester, Mass, looking at the case fatality rate for patients with AMI-CS over time. And we can see that improving trend in mortality. If we go on to the next slide. But I guess the important thing to say is that still mortality is really very high, which I highlighted in the very beginning. Another thing that's really interesting when we're thinking about the epidemiology of shock is that there has been an evolution, no question, in terms of what are the causes, the underlying causes or etiologies of cardiogenic shock. All the data I've showed you so far is in the context of AMI-CS. My colleague David Berg within our registry looked at, you know, what type of patients are presenting with shock in our CICUs. You know, in terms of all comers, about 2/3 had cardiogenic shock. But when he dove down and drilled into what are the causes of cardiogenic shock, what he saw was that actually only 1/3 of them had AMI-CS, which is where most of the attention has been to date. And actually half of them were coming in the absence of an acute MI with some other process, whether it be sort of an ischemic cardiomyopathy, but not acutely presenting with a heart attack, or a non-ischemic, some sort of non-ischemic presentation. And that was 50% of the patients. And this has been a consistent signal that we're now seeing. So if you move on to the next slide, within the cardiogenic shock working group, they found really the exact same thing, that of all the patients that they had in their registry with cardiogenic shock, only again 1/3 were AMI-CS, and then half of them had this heart failure cardiogenic shock etiology. And why does this matter? Well, the patients are different. And so if we move on to the next slide, their course is different. So an AMI shock patient, they are well, they have a heart attack, they come in, they've decompensated, and they're in shock. A heart failure shock patient may have sort of a more of a stuttering course where they have some heart failure, they get compensated, they decompensate, and then ultimately that may manifest in their presentation to you with cardiogenic shock. So it can be a stuttering course. And, not if we move on to the next slide, it's sort of interesting that there may be some relevance to that stuttering course. My colleague David Berg and Ankit Bhatt did a study within the registry where they said, let's look at our cardiogenic shock patients, define them as either they're coming in with acute myocardial infarction, with this stuttering acute on chronic heart failure shock, or with heart failure shock, but they've never had it before. This is their first presentation. And we can probably ignore that middle section, but if we kind of look at the right hand, what we see is those people who have, AMI-CS have a very high mortality, 38% there. Those who have their first presentation of sort of heart failure that's manifest in this severe form of cardiogenic shock also have pretty poor outcomes. And then those who've had this stuttering course, while their mortality is still high, it looks better than those other folks. And there's sort of an idea here that maybe there is some chronic adaptation that happens in those patients who have this stuttering course that allow them to sort of, a physiologic adaptation that allow them to do better over time. So these kinds of subclassification matter when we're thinking about what somebody's course might look like. If we move on to the next slide, another thing that has been, I think, really a game changer in the field has been the SCAI shock staging, or the Society for Angiography and Intervention, where they came out with these criteria to define patients as, along their severity of illness of shock, so that we can really communicate with each other, so that we have the same language. And we can say, we have this patient, who is at risk for shock, but they don't have shock. They have heart failure, they've had an MI. Somebody who looks like they're slipping into shock stage B, but they're not hypoperfusing. Somebody who's in shock, classic cardiogenic shock, where they have evidence of hypoperfusion, but they're not, they're sort of stably in shock. We have patients who are stage D who are deteriorating. Despite what you're doing, they're looking worse. And then we have patients who are E, who are extremis, where they are on the verge of death and cardiovascular collapse. And this allows us to have a language to define, and to speak to each other, and to kind of say, I have this patient who's stage E. Everybody knows what that means. But interestingly, when this classification has been carried into a whole bunch of different data sets, if we move on to the next slide, I'll show you one from mine and then from our data set within the C3TN, and then others next. But another reason why this is so important is not only being able to communicate with each other, but also because clearly this is a very nice way of risk stratifying our patients. So what you have here is all patients with cardiogenic shock stratified according to the SCAI staging. And if you go on to the next, thank you, that this classic cardiogenic shock, which is, they're in shock, they're hypoperfusing. Their in-hospital mortality, which is the hashed bars there, is 16%. And we always cite mortality rates in cardiogenic shock on the order of 30 to 50% in contemporary data sets. So then those who are deteriorating or extremis obviously have very, very poor outcomes. But it's really important to kind of say, there are within our shock population, there are very different subpopulations. And as we're thinking about doing clinical trials, as we're thinking about feeding back to families about expected prognosis, it's very helpful to have this language. If you go on to the next slide, this same analysis, where this was applied, the SCAI staging criteria was applied to many other studies, registries of cardiogenic shock, those in the CICU, out of hospital cardiac arrest. And we see this gradient of mortality based on the SCAI staging classification. So a really important, I think, tool now for us to use in how we think about our patients. And then if we go on to the next slide, this has also been, I won't spend a lot of time on this, but we're also trying to take it a step further. This is work from Jake Jenser out of the Mayo Clinic, where he's sort of saying, well, what happens if we look at how somebody moves through their course in terms of whether their SCAI stage gets better or gets worse or doesn't change? And the take home is that, of course, if somebody's worsening, their outcomes are worse. Somebody sort of goes from a bad stage to a better stage, their outcomes are better. So it just allows us to sort of understand trajectory using this terminology, which I think is also going to be very helpful going forward. If we move on to the next slide. I'm sort of giving you a number of different things to think about: the etiology, the severity. There's this sort of important distinction in terms of the pathophysiology of whether somebody falls into a classic cardiogenic phenotype where they have a high SVR, or whether they are vasodilatory cardiogenic shock, or another term for that is mixed shock, where their SVR is low. And the reason why this is relevant is, if we move on to the next slide, there's this classic construct by Judy Hockman and her team, the shock spiral, where shock begets more shock, and ultimately patients spiral into more multi-organ system failure and death. And down this spiral, when patients are hypoperfusing, they have an inflammatory cytokine release, they become vasoplegic. That drives more hypotension, more hypoperfusion, and everything gets worse. And so for many patients, mixed shock is them coming down or spiraling down the shock spiral. So it's relevant, if we go on to the next slide, where sometimes what that means is, this is a small study that David Berg did out of the C3TN, but we sort of get the sense that those patients who are mixed might actually have worse outcomes than patients, for example, who are heart failure, cardiogenic shock patients, which here is labeled CS without AMI. But just the notion that those patients may be sort of, moving down that unfortunate spiral. And so outcomes may be worse when you see somebody with a vasodilatory state superimposed on their cardiogenic shock. If we move on to the next slide, I think I just have a few more things to cover. I had mentioned the sidedness of shock. It is something that we think a lot about, especially when we're thinking about our mechanical circulatory support options. Are we going to support one side? Are we going to support the other side? Are we going to support both sides? It's also relevant for the outcomes of our patients. This is a study from the Cardiogenic Shock Working Group, where they said, do the patients have elevated filling pressures on the right, on the left, or both sides? And so that's the both sides is by V. And generally speaking, the conclusion was that a right-sided involvement is bad in terms of mortality, as is biventricular involvement. So that sort of, as you start to see people who have right-sided involvement, we worry about those individuals. If we move on to the next slide. And I won't spend much time on this. It's very complicated, but a very complicated slide. But within the C3TN, David Berg looked at parameters, hemodynamic parameters that are independently associated with mortality. And to reinforce the last 2 points that I made, what he found was people who have a lower mean arterial pressure, or a lower who are more vasodilated, and people who have higher right-sided filling pressures, more RV dysfunction, have worse outcomes. So it's sort of a validation of the data that we've seen before. Again, for those who lose their tone and have right-sided involvement, outcomes are worse. And then if we move on to the next, I'll just go through this very quickly to say that there are many people who are thinking about incorporating even more data that we collect in our patients. That we have imaging, we can use biomarkers to try to better understand our patients and to kind of deeply phenotype them, both in terms of understanding the underlying pathophysiologic mechanisms, but also outcomes. And so without belaboring, and if we move on to the next slide, there was an effort done by the Cardiogenic Shock Working Group where they said, we've got all of these parameters, hemodynamics, metabolic variables. Let's see if we can identify profiles of patients. If we move on to the next slide, and they did, they found 3 different clusters of patients: those who they defined as non-congested based on the hemodynamics, those who had sort of cardiorenal syndrome, and then those who had really deranged metabolics. And ultimately, they saw that these different phenotypes tracked with mortality. So I think that's kind of the future, is saying we're going to take all this huge amount of data we have and try to better understand our patients. And so finally, if we could just move on to the next slide. This was a nice summary by Jake Jenser in Jack Advances, where he kind of said there's all of these things that we're starting to think about. Phenotype and all of the various different elements that we've talked about, like, the acuity or chronicity, the etiology, over to the left, the shock severity, thinking about sky stage. The bottom, risk modifiers. So for example, are they systemically inflamed with a low SVR state when we're thinking about risk stratification? So it's becoming more complex, nuanced, but I think all of these nuances are quite important. And so if we move on to the final second to last slide, just to summarize, kind of a whirlwind of the epidemiology of cardiogenic shock. Again, the scope is significant. It's very prevalent, at least where I spend my days, which is in the cardiac ICU. We know that it carries a lot of morbidity and mortality, and that, again, the epidemiology is evolving, and it's evolving, I would say, quite rapidly to all of the sort of nuance that we have. And really, a lot of that understanding is coming from multi-center collaborative registries. And so if we move on to the next slide, this is just to say, to all of you, thanks for your efforts in your participation in the AHA Cardiogenic Shock Registry. This is just going to be sort of massively important in furthering our understanding of the patients that we care for. So with that, I will stop and happy to take questions.
Thanks so much, Erin. That was fantastic, truly a whirlwind overview, but really gives a state-of-the-art view of the field that's extremely broad. We don't have any questions in the chat, but while we welcome if there's any from folks on the line to unmute and ask, maybe to just get things started. I'll ask, maybe even just going back to the very beginning, are there any pearls you have for the recognition of shock? Because that is the very first step and pitfalls that we make in not identifying patients.
Yeah, no, it's a really good point. I think that for many people, the sort of easiest trigger is seeing hypotension. In terms of recognizing potential shock. I think what I have taken away from my years in practice and also from yours and Dr. Krukoff's sort of standardized definitions is really what the core should be is recognizing the hypoperfusion, right? Because not everybody is hypotensive. And so seeing that constellation of things, the lactate elevation, the acute kidney injury, the acute, liver injury, where you start thinking this smells like shock and then sort of further, defining it as what it is and the type of shock. So I think it's that pattern recognition of hypoperfusion, which is so critical.
Thank you. That's really helpful. I think what we will do is to keep on time. We're going to keep you on and have you join for the Q&A as well after Dr. Garfinkel. And then we'll have more opportunity for discussions then, as no doubt will be prompted by the case. So I introduced Amanda very briefly at the beginning, but just to say again, she's one of our outstanding fellows in cardiovascular medicine at the Brigham and a leading force in moving forward medical education for us. So very pleased to have her join. Amanda, take it away.
Thank you so much. Thanks to everybody for joining and to Dr. Morrow and Dr. Krukoff for inviting me to be part of this wonderful forum. As said, I'm Amanda, and I am one of the second-year general fellows at the Brigham pursuing critical care cardiology. You can advance the slide. I have no disclosures. So this is a case of a 71-year-old male with diverticulitis and alcohol use who presented to an outside hospital with dyspnea on exertion for 1 month that had worsened over the last 3 days. On his initial EKG on presentation to the emergency department, he was found to have sinus tachycardia with ST elevations in AVR and V1 and deep ST depressions diffusely. This was concerning enough about a STEMI equivalent that he was taken urgently to the cardiac catheterization lab. Advance the slide, please. So on hospital day 1, his coronary angiogram revealed non-obstructive coronary artery disease. He had a left heart catheterization at the same time that showed a markedly elevated LV end diastolic pressure of 34 millimeters of mercury. During the case in the cath lab, he required escalation from 5 liters nasal cannula up to BiPAP, and he was admitted to the intensive care unit for diuresis. In his second day at the outside hospital, he underwent a transthoracic echocardiogram, which showed a normal left ventricular size with reduced left ventricular systolic function with an EF of 25% and diffuse hypokinesis with regional variation. He had normal right ventricular size and function and no significant valvular disease. Over the course of the afternoon, he unfortunately developed progressive hypotension with diuresis, as well as episodes of non-sustained ventricular tachycardia. And that evening, he had a monomorphic VT arrest requiring multiple shocks. He was intubated and electrically stabilized on a combination of amiodarone and lidocaine. On day 3 of his admission, he developed progressive multipressor shock, and his repeat transthoracic echocardiogram demonstrated new severe RV dysfunction in addition to his severe LV dysfunction. At that point, a request for transfer to our cardiac ICU came in. Next slide, please. So to summarize, this is the patient that I was the fellow in the cardiac ICU overnight, and we're accepting this gentleman from an outside hospital who has a newly identified non-ischemic cardiomyopathy, who was transferred to us in multipressor shock after a monomorphic VT arrest. His vitals on arrival to our unit were a blood pressure of 82/64, and that was on norepinephrine at 40, epinephrine at 10, and vaso of 0.04. He was afebrile with a heart rate that was only 62 beats per minute, despite him being on a significant amount of positive inotrope. His saturation was 97% on volume control ventilation with a tidal volume of 400, a PEEP of 8, and an FiO2 of 40%. His exam was notable for a gentleman who was intubated and well sedated. He had a regular rate and rhythm with no murmurs and a jugular venous pressure elevated to 15 centimeters of water, and his extremities were cool with no edema. I haven't included all of his labs, but the notable ones were that his lactate at the time was 1.7. His NT-proBNP was elevated to 11,000. His high sensitivity troponin T was 3,200 and had been as high as 5,200 at the outside hospital. His erythrocyte sedimentation rate was elevated at 62, and high sensitivity CRP was elevated to 132. You can advance, please. Given his hemodynamic instability, he underwent an urgent right heart catheterization, which showed elevated biventricular filling pressures with a CVP of 20, a pulmonary capillary wedge pressure of 30, a pulmonary artery pressure of 52/30 with a mean of 39, and a PA saturation of 55%. At this point, his MAP was 93 on that norepi of 40, epi of 10, vaso of 0.04. And those numbers calculated out to a FIC cardiac output and index of 4.0 and 2.0 respectively, with an SVR of 1200, systemic vascular resistance of 1200 dynes per second per centimeter, a PAPI, pulmonary artery pulsatility index of 1.1, and a CVP to wedge ratio of 0.67. With this, we're going to bring up a poll question for the audience. How would you characterize his hemodynamic profile at this point? Oh, I think we've advanced a little quickly. If we could advance backwards. Yep. And I think we're going to activate the poll now in Zoom. Rachel, is that? There we go. Okay. So the question is, how would you characterize his hemodynamic profile? And this we're calling on Dr. Bahula's talk. We're thinking about how do we classify this gentleman? Is this SCAI stage C cardiogenic shock with predominant RV failure, SCAI C shock with predominant LV failure, SCAI D shock with predominant RV, SCAI D with predominant LV, or SCAI D with both RV and LV failure? And we'll give about 30 seconds for everybody to look over these numbers, and then we'll hear from Dr. Bahula.
And take your time. We should have warned you that there would be a quiz, so to speak, and it's all anonymous. So please give it your best shot. And there'll be one more question after this too, so you're prepared.
And we're at 40% participation so far, just as an update.
Great, Shana. You can let us know when we're at time because you're monitoring, and let us know when to move on.
I think we can give folks another maybe 10 seconds. We're almost at 50%.
Perfect. Why don't we go ahead?
Yep. All right. Let's call it.
All right, are you able to display the result? Okay, great. So it looks like we have some of what is spread in our answers, which is great. And it seems like the majority is thinking about a SCAI stage C cardiogenic shock with predominant LV failure, with a strong second majority is thinking about SCAI D cardiogenic shock due to biventricular failure, or SCAI D due to predominant RV failure. So Dr. Bahula, if you could walk us through sort of how are you thinking about this question, and how are you interpreting his hemodynamic stage at this point, and thinking about prognostication as you're meeting this gentleman?
Yeah, I mean, so I guess, first question, is there shock? And of course there is. You've walked us through nicely the sort of progression of this patient with hypoperfusion, with cardiac insufficiency. And in terms of defining the SCAI stage, I guess what I would say is, this patient is just from the last couple slides, you've shown us this rapid deterioration, and now is on multiple pressors, and so would fall into the category of at least SCAI stage D, on a whole lot of vasoactive therapy to have a borderline cardiac index. And so I think, D of the options there is the one I would choose. And then, in terms of the sidedness, I didn't mention this as much in my talk, but certainly there's left-sided failure without a doubt. We have a wedge of filling pressure of 30. The right-sided filling pressure, the CVP is also elevated, but Amanda's nicely given you some other hemodynamic data there about the PAPI being a little over 1 and the CVP to wedge ratio being on the lower side, which suggests that it's a little, there certainly is some right-sided involvement, but I would say, dominantly left-sided involvement, where we oftentimes are thinking about, a threshold for a PAPI maybe of 1 and a CVP to wedge ratio of 0.86, high being better for the ratio, and PAPI, also, sorry, low being better for the ratio, and high being better for the PAPI. So anyway, I would choose D as my answer.
Excellent, thank you. So, and I think one other thing I will just highlight based on these hemodynamic numbers is, as Dr. Bahula mentioned, mixed shock does carry a worse prognosis. And if we look at his systemic vascular resistance of 1200 on norepinephrine of 40, epinephrine of 10, vaso of 0.04, he's on quite a lot of significant vasoactive agents, and vasopressor agents, in order to maintain an SVR, making us think that if we were to remove those pressors and his SVR were low, we are dealing with some vasodilatory component as well. So he is presenting, while I focused on the cardiogenic portion of his shock, there's certainly evidence of some component of a mixed shock here. So with that in mind, I agreed, we were characterizing this gentleman as SCAI stage D cardiogenic shock with predominant LV failure. And based on that characterization, our next polling question for the audience, if we can go backwards, is, what would you do next with this gentleman? If you were me and you're the fellow in the cardiac ICU meeting this gentleman with SCAI stage D cardiogenic shock, non-ischemic cardiomyopathy due to predominant LV failure, which of the following might you do? Would you consider cross-titrating from norepinephrine to dobutamine? Might you initiate VA ECMO for biventricular support? Might you place an intra-aortic balloon pump for left ventricular support? Place a temporary left ventricular assist device, such as an Impella CP for LV support? Or E, obtain an endomyocardial biopsy and place a temporary left ventricular assist device or Impella CP for LV support? And we'll give the audience a little time to answer this question as well.
All right, just about 50%, maybe a few more seconds to get your answer in.
All right, that feels about right, Shana.
Okay, great. So it looks like we are having a majority of participants thinking about a temporary left ventricular assist device. And we have, a difference in some people are thinking about an endomyocardial biopsy. Some people are not thinking about an endomyocardial biopsy. So Dr. Bahula, we'd love your input on this question.
Yeah, I mean, I think that is the big difference between the answers there. I mean, the course, as you were describing this patient's course, or no epicardial coronary disease with a really significant troponin elevation and really precipitous decline, both sort of subacutely with his symptomatology, but then also acutely here in the hospital. I very much worry about myocarditis in this patient, and for that reason, I would love a biopsy because I'd like to understand what's the etiology, and do I need to target my therapies based on that etiology? So I would love a biopsy, and I think you've given it a really good effort with vasoactives at this point, and the patient's kind of just hanging on, and so I think it's very reasonable to place temporary mechanical circulatory support. And in our institution, we would usually start with, as you said, we'd probably start with the left-sided one. Some institutions might reach for ECMO in this patient who, but the oxygenation from what you showed us was not that bad. That's obviously what you get with ECMO plus biventricular support. And so I think I would start with E, where I would biopsy and then also place a left-sided device.
And
Yeah.
do you want to comment just very briefly on whether you would consider trying to switch to dobutamine, and would you ever use a balloon in this type of patient?
Oh gosh, yeah, it's a really good question. I mean, you did have, with all of the vasopressor that you had on, the 40 of Levophed and the vaso, you had a MAP of 93, and so you might be able to squeeze on some dobutamine on top of that, and you might still have enough blood pressure. If you're aiming for a MAP of 65, say to 75, something in that range, you could squeeze on some dobutamine on top of that. I suspect you would not be able to get off of norepinephrine and still maintain MAPs that are, thought to be sort of perfusing, above our target normally of 65. So because of the vasodilatory component of dobutamine and the vasopressor element of norepinephrine, I don't think you could just swap them. You might be able to layer dobutamine on top. And then for the intra-aortic balloon pump, I just think, he's in really profound shock, and my opinion, and I think many others, of the balloon pump is it's just not going to be enough support in this situation. You might get, a half a liter to a liter more of cardiac output in that setting. And I just don't think it's going to be enough to carry this guy through. So I think you do need, I think of this patient as needing more support than that. And so I would reach for something that gives me a little bit more flow, a little bit more cardiac output.
Excellent. We can advance. All right, so that is what we did. We did obtain an endomyocardial biopsy and place a temporary LVAD. So on the CCU day 1, the temporary LVAD was placed. It was initially at P9, the highest power level. But with that, one of the major complications we worry about with the left ventricular assist devices is hemolysis, and he had significant hematuria at a high power level immediately upon arrival back to the cardiac ICU. And his LVAD was actually placed a little bit far out into the aorta. So we actually had to advance it at bedside to address the hemolysis and wean it down to a lower power level. An endomyocardial biopsy was obtained in the cath lab, and given a strong suspicion for fulminant myocarditis, as Dr. Bahula mentioned, we empirically began 1 gram of Solumedrol. On CCU day 2, his endomyocardial biopsy did result with classic features of lymphocytic myocarditis, and the histopathology there is from his endomyocardial biopsy, showing that between the myocardial cells, there's this predominant lymphocytic infiltrate, and there were no giant cells seen. So in addition to continuing on pulse dose steroids, he was started on IVIG 1 mg per kg for 2 days, which has some evidence for treatment of fulminant lymphocytic myocarditis. He was having ongoing issues with hemolysis, so the temporary LVAD was weaned to P5. And in those first 2 to 3 days within the unit, he also required initiation of continuous renal replacement therapy for oliguric renal failure. By day 4 to 5, after his treatment with IVIG and steroids, his echo actually showed significantly improved biventricular function. His temporary LVAD was able to be removed, and he was continued on some low-dose norepinephrine for MAP support. And by day 5, he was extubated to nasal cannula. Next slide, please. Unfortunately, after this initial course, while he did quite well initially, he had remained in the hospital for a long time thereafter. From hospital day 5 to 15, he remained in the cardiac ICU due to ongoing need for renal replacement therapy, low level pressor requirements, and had significant delirium. He was transferred out to the floor on day 15, but on day 19 had to go back to the cardiology floor after he had an episode of R-on-T with polymorphic VT arrest in the setting of a long QTC. On day 30, he was transferred from our cardiac ICU back to a hospital closer to home for ongoing management of his delirium, and he was discharged home with services 15 days later. In January of this year, he was seen for a post-discharge visit in the cardiology clinic, and he appeared and felt well, was regaining his strength with physical therapy, and is continuing to require hemodialysis 3 times per week, but is hoping for renal recovery. You can advance. So that's our case presentation, and I'm happy to open up to questions.
Yeah, no, thanks very much, Dr. Garfinkel. That was fantastic. And that entirety of his course really illustrates the complexity of these patients and both the early management and all of the end organ sequelae. Maybe, Aaron, I'll ask you to just comment very briefly on whether we would consider using an Impella 5.5 in this situation, when you would, and whether that would have been an option too in this case.
Yeah, no, it's a really good question. I have to say I've sort of come to appreciate how these decisions can be very institution specific. You know, there are certain institutions who, in this case, might love ECMO. That might be their go-to. You know, but you know, at our institution, we tend to use more Impella, I would say, at least as a first line, and then we may escalate up and step up to ECMO. You know, we use a lot of the CPs, the Impella CPs, because of sort of the ease of placement and just doing it acutely in the middle of the night when somebody's decompensating. But we also have more recently used the 5.5, so the surgically placed axillary devices. One, they provide more support, and this patient clearly needed a significant level of support. And two, you know, anecdotally, and I don't know that I've seen data around this, but anecdotally, there may be a little bit less hemolysis with this sort of larger device. And obviously that's something that you, Amanda, were struggling with this patient and their course. And so, but it's a logistical challenge to you know, have to have the surgeons be able to sort of take them in relatively short order, take them to the OR and place this device. So I like the 5.5. I think it would be a very reasonable thing to provide a heavy level of support for this patient for a little while. But logistically, it's sometimes challenging. So that's kind of a wishy-washy answer, but.
Well, perceived need for a high level of support, definitely worth considering. It really depends on the timing that you need to escalate. So Amanda, thank you very much. Terrific case, very educational, great conversation. So now I'm going to turn things over to Mitch Krukoff, who's a professor at Duke University, co-chair of the HA Cardiogenic Shock Registry. Mitch.
Thanks so much, David, and welcome everybody. It really is exciting to kick off this Grand Rounds experience. Next slide, please. So I'm going to give a very high-level overview of the American Heart Association Cardiogenic Shock Registry. This is the first dedicated national professional society shock registry in the world. The registry's mission here is to better understand the clinical manifestations of varied shock phenotypes, management patterns, and outcomes in patients presenting with cardiogenic shock to hospitals across the nation, and to improve the quality of care. And the discussions we've heard so far today give us all the reasons for that. Next slide, please. The core scientific aims of the shock registry, if you click once, include characterizing epidemiology, like we walked through today. Click again, please. The intention is also to provide evidence from this registry that can help move best practices forward on an evidence base. Next click, please. As well, this registry is set up to support regulatory evidence collections for newer, safer devices, as well as clinical research infrastructure to lower the costs of doing shock research. Next click, please. We also intend this as a means of piloting evidence-based performance metrics so that individual sites can get quality metrics feedback. And last click, as well as to understand the role of health equity, diversity, in the shock patient population and their care. Next slide, please. So to support these varied missions, if you look at just the steering committee that leads the shock registry, it is a very diverse group combining academic clinician experts in heart failure, critical care, cardiac surgery, and invasive cardiology. It also includes the participation of industry experts who manufacture MCS devices, regulatory experts from the US FDA, policy and payer experts, including from CMS, and really phenomenal. I just can't, I could spend the whole time describing the AHA staff who have been dedicated to leading and making this happen. Next slide, please. I'm not going to dive into every moment of the milestone since we launched just 2 years ago, in fact, barely 2 years ago, other than to say that this is the first time I've ever worked on a project like this where we came in ahead of time on virtually every calendar-based milestone, and we are now approaching 100 activated sites and almost 4,000 patients at a clip of 300 to 400 per month. Next slide, please. This map will be my one hope that anyone who has logged in today who is not interacting with the AHA shock registry mechanism, particularly those of you who look in the bare spot in the Midwest there, we would love to have you make contact. Shana is the point person, and again, a phenomenal group. But we hope to continue to expand along these lines. And now to give you a flavor, next slide, of just what does it look like from the site's perspective, or can it look like? I'll take you back to Jason Walchuk, our guru of health IT, to give us a demonstration of what is the door you open to evidence from your own site about your own patients, courtesy of the American Heart Association. Jason?
Thank you, Dr. Krukoff. I'm going to share my screen. So thank you, everyone. It's a pleasure to be with you. Just going to take a couple of minutes just to kind of tie a little bit this together and relate it to the the Cardiogenic Shock Registry here at the American Heart Association. Those of you that participate in the registry, this may look very familiar to you, but I hope even if you do participate, you'll glean a little bit of something related to some of this additional reporting that we now have provided within the registry for you. And those of you that don't, this is an opportunity. This is an opportunity for you to participate not only in the registry to contribute to the wealth of knowledge and the ability to have clinical data on these important patients, but also we provide tools within the system itself to allow you to look at the care patterns of your patients, comparing yourself to different comparators across the country and your region. And I'm just going to kind of drill into a little bit of that. So what we're going to show today, just really quickly, is some of the standard reports that are provided to you within the system. As the data is entered into the system through our simple case report form, the data is ready for reporting within a couple of minutes. So it's real time. As you enter data in, you're able to run any of these type of analytics. I built out just kind of a standard report here, looking at a couple metrics that we have standard within the system: in hospital mortality, potential MCS complications, and then average ICU length. And then I added some benchmarks. And what these are aggregate groups of hospitals that have either similar characteristics as my hospital and or geographical locations. So you can see Northeast, but then I also have a tag for non-academic center, which my test site is, and bed size. Those are all completed on the facility form, on the form management. So if you participate and you have not gone in there, go in there and you can actually have access to some of these benchmarks as well. And then the power of the system allows you to kind of slice and dice the data to look at different analytics related to your care, utilizing any variable that's within the registry. So I just threw a few in here just to look at. We're going to look at point of origin, sky stage, and then also sex for some comparators. So you hit apply parameters and the report then renders. It allows you to navigate in and out of all the canned reports. So the report I'm looking at right now is MCS complications. If I can simply change this over to the in-hospital mortality measure, and it gives you a visual representation of a simple bar graph to show myself. So my hospital is in red. And then I have comparators of all hospital, non-academic hospitals that participate in the CS registry, 399 beds, and then that Northeast census tract. here in pink. So this is a basic report for mortality. But the power here again is to do those analytics and really drill down into the patient population. So if I then want to come over here, comparators, and I'm going to switch this over to look at, now I want to look at my in-hospital mortality, but by sky stage. I can open that up. And then I can open my filter pane over here on the right-hand side, and I have a little bit more fine tuning that I can drill down into the patient population as well. So if I want to turn off all the sites and all the data that have the sky stage missing, I can deselect those. So now I'm truly looking at B through E, and I can look at the comparator of my mortality for my hospital compared to the other benchmarks related to the stratification of the sky stage. One other view of this, so this is nice looking at a bar chart, but we all want data tables. So you can actually click on measure details. This will allow you a drill down into the data population. This is all movable, so I can expand it. So I have each of my groups. So here's my benchmarks, all hospitals, my hospital. I have my numerator denominator percentage related to that. All this is exportable, everything you see. So I can export it out to a CSV and XLSX for Microsoft Excel. And then for my hospital data, I actually get an integrated case list. So if I wanted to actually drill down into all of those patients that fall into the mortality report, I got 4 here. I can just scroll over. I can see what stage they were in. I could also see every variable that's used in that particular metric. And again, all portable. So all this could be exported out to answer any questions that you have. So aside from that, we fine-tuned in to kind of look at that report. We could also do a number of different things on here. Let's say this is getting too cluttered. I wanted to just drill down in my meeting to look at, let's say, geographic locations and all hospitals and mine. I could deselect those benchmarks. They go out of view very easily, and you can see I could turn them back on. Then we can also leverage filters to drill down even more over here on the right-hand side, where if I then want to look at mortality by sky stage, but only in my male population, I can filter out the females and drill down into that. And I can do it conversely to just look at my female population. You can see how you can apply filters on top of filters and comparators to really drill down. And then you could turn all this off at any time, reset your filters, you're back to your standard data set for you to then do more analytics. Another view would be, we also, in addition to rate-based measures, we also have these categorical measures, which this one in particular is average ICU length of stay. And this actually, you could do the same principles of drilling down into those separate populations. And I'm going to stop there. Dr. Morrow, turn it over to you.
Thank you very much, Jason. I mean, it's really amazing the type of real-time data display that you can do as a participating site and allow you to gain a tremendous amount of insight. These are the type of data that we've not usually had access to within our own system, and so this really is an amazing tool. So in our remaining minute, I just want to go ahead and bring back our faculty, and I'd say maybe I'll open up to either Mitch or Aaron. Do you have any recommendations for ways? This is a question from the audience. Do you have any recommendations for ways to help with cardiogenic shock recognition for patients on non-cardiology services? How do you let your colleagues know when to call you and reach out? And maybe I'll ask Mitch to go ahead.
David, it's a great question, because clearly cardiogenic shock, for instance, in the surgical universe, for all of the nuances that Dr. Bahula walked us through, that's another one that has its own sort of uniqueness in many ways. And the tradition of working separately versus a word we've used a number of times this morning that I'm in love with, working collaboratively, is really the key to making these patients better. The one other thing that I will point to that the Shock Registry is very interested and focused on also in the real world is that we have in many regions configurations of hub sites and spoke sites, and the diversity of response, the diversity of patients that actually incorporates is another arena that I think we all need to learn about how best to handle. And in going forward, I hope is another area where collaboration will give us better pathways for these patients.
Well, Mitch, I'll say I think that is a perfect word to close on the collaboration. We want to welcome all of you who joined this symposium broadly, and particular thanks to all of you who've already been participating in the HA Cardiogenic Shock Registry. We definitely want your feedback on how to incorporate things of interest to you in the future grand round session. So please email us at the cardiogenicshock@heart.org. That's on the screen now. I want to thank our fantastic faculty, really terrific presentations, both Dr. Garfinkel and Dr. Bahula. And thanks to the AHA team for putting this all together. So with that, we will close and look forward to next time. Please reach out if you'd like to participate in the registry or if you have any suggestions for our future sessions. Thank you.